coffee. We're going to get started in about 60 seconds. Out of 15, I think so. It's close enough. Never seen it. Well, that coffee looks good. No, I'm just kidding. I'm kidding. No, I'm just teasing. I'm teasing. I got to drink right. I just had to. I couldn't resist. Good evening. I'd like to call to order the meeting of the Governor's Emergency Medical Service and Trauma Advisory Council for November the 25th of 2013. The first item on the agenda is approval of minutes. We have a motion and a second. Any discussion? All those in favor? Aye. All opposed? Under Chair Report and Discussion, as we always do, we need to remember our vision and mission. Our vision is a unified, comprehensive, and effective EMS and trauma system for a healthy, safe Texas. And our mission is to promote, develop, and maintain a comprehensive EMS and trauma system that will meet the needs of all patients and that will raise the standards for community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. If any of you have your electronic devices, if you'd set them on stun, that would be helpful for all of us. And I've taken the time to look at both archive and real-time footage from these meetings, and it's very, very important that when you're speaking, pretend you're trying to eat the microphone, because we've had people commenting they can't hear. So don't be afraid to get too close to the microphone. The other comment I have is to my left, we have a distinguished gentleman, as you all know, and Dr. Stewart is going to be the chair on the Committee on Trauma for ACS, and we would like to take the time to congratulate you. That's not only good for you, but for all of us. Next item we have on the agenda is the Assistant Commissioner report. Commissioner Perkins.
Good evening. I will be combining my report with Jane Guerrero's. Unfortunately, she is under the weather, and we miss her tonight. I'm hoping we get to see her tomorrow. So the first thing that I want to talk to you about today is implementation of legislation. That's always our number one priority coming out of a legislative session. We did have a recent stakeholder meeting over hospital licensing rules. There was not much out of that legislation, and I think those are moving forward smoothly. Information about them is on our website. The biggest one, of course, the biggest pieces of legislation are Senate Bill 8 and House Bill 3556, and so let me talk about those for a couple of minutes. I've already had 2 meetings with the sponsor's office about this legislation, Representative Colcourt's office, and I have another meeting scheduled with her office again next week. The first meeting was with her, the second with her staff. I don't know for sure about the one next week, but she is certainly monitoring the implementation of 3556 and Senate Bill 8 very, very closely. So far, in general, the implementation has been, of the key components, has been fairly smooth, including the moratorium on new licenses for this fiscal year. We've had a few issues with the letter of credit, but nothing that has not been able to be overcome that I'm aware of at this point. We have been working with HHSC on the logistics of the surety bond, and we're very close to having that final, and that information will be put on our website. For anybody that's renewed their license in the since 9/1, we've basically told them that the information about what they'll have to do in regards to the surety bond will come out when we finalize that work with the logistics with HHSC, and we'll give them some time. What did we say, 30, 60 days, 90 days? We'll give them enough time to get that surety bond. From what we can see, it's not going to be that difficult. I think HHSC was misunderstood, that the expectation was that everybody, new licenses and renewals, would have it at that time and not wait for 5 years when they renewed as their provider enrollment with Medicaid. So we're working on that, and the details should be coming out, we think around January 1st, but it could be a little bit later. There's been a lot of work around the rules. There's been multiple meetings, I believe 7 meetings around the state to provide input on the rules, as well as the report that is required by Senate Bill 8. Health and Human Services Commission, HHSC, the Texas Medical Board, and DSHS are all 3 charged with providing a report to the legislature. It's due on January 1st. What the decision was, we've had multiple meetings with HHSC and the Medical Board to talk about coordination of that report. And right now the plan is to submit 1 report from the 3 agencies, and each agency would have their own section. Now, it's potential that Medicaid may split off because they're just so big, and so, but right now the plan is still to submit 1 report from the 3 agencies. The Texas Medical Board and DSHS have drafted the background information and submitted that to HHSC already. We're under some very tight deadlines. The report is due January 1st, although we may not quite make that date. And then the information from the stakeholders meetings we've already received from EMS committee, and we'll be looking at that and putting that together and sending it to HHSC. So I think there will be 1 report coming out, but I don't know that for sure. I think we have a meeting with them coming up in the middle of December to see where we are on that report. I think that's it on 3556 and Senate Bill 8. Do you all have any questions? And as you know, there is also a CMS moratorium that went into place, I believe, July 29th for Harris County and the surrounding counties for enrollment in Medicare. And I have not heard anything. It was for 6 months, and it may be renewed for another 6 months, but I have not heard anything about from CMS about that moratorium. Any questions about that? Okay. The second big, and if you can believe this, we will be starting to work on our legislative appropriation request. The agency will start working on that in January and February. It's just amazing to me how quickly it turns around, because we have to turn our legislative appropriation request in for the next session in August. So we'll start working on that after the holidays. The other big issue that we're working on is sunset. The sunset process for HHSC and the 4 agencies under it began really in full swing within the last month and a half to 2 months. Dr. Lakey gave an overview to Sunset Commission about our agency. Then I gave an overview about the division. And then they've been having multiple meetings about the budget process, about contracting, in many different parts of our agency. Now they're kind of honing in on issues that they're particularly interested in, and one of them is EMS trauma. They're interested in both from the regulatory perspective as well as the system perspective. So we anticipate answering questions about the EMS trauma system sometime in the next couple of weeks. They may go out. You all should have received an email from them, and if you didn't, I need to know about it. From the Sunset Commission, we provided the information on all advisory committees, and they would have sent you an email, individual emails to all of you, asking for, giving you the opportunity to provide input. So if anybody on the council did not get one, just let me know. But you should have, and I'm seeing nods.
That's the survey that they sent out?
Yes,
okay.
And also the ability to provide input if you want to. There's also an ability for stakeholders to provide input to the Sunset Commission. I believe the information's on our website how that can happen. What will happen at this point is they're going to continue to work with the agencies over the next few months with their goal of finishing the kind of assessment of DSHS around April-ish, the end of March, April. Then they will come out with a report around May. And then there will be meetings held, and I'm not sure exactly how this is going to happen, but they will have open meetings, the Sunset Commission, for stakeholders to provide input. Ultimately, the Sunset Commission will vote on the Sunset recommendations, and then those recommendations that are voted on to move forward by the Sunset Commission will become legislation to continue, we hope, we believe, DSHS, and then any recommendations they may have for changes to DSHS laws. Any questions about that? It's an intensive process. Okay, those are the two major issues that I wanted to talk about. From Jane's side, you have a document. I'm not going to go into detail today, but you have a document in your packet, Office of EMS Trauma Systems Report to GETAC. It shows you the number of trauma facilities we have at each level right now, as well as stroke, and it goes into details about our funding programs. Just let us know if you have any questions about it, but I'm not going to go into detail tonight on that. And then finally, I've got some key staff changes that I wanted to tell you about. First off, two of my EMS compliance managers, Fernando Posada in San Antonio and Marilyn Talley in Houston, have switched places. Marilyn has moved to San Antonio and will be taking over that region, and Fernando Posada has moved to Houston and will be taking over that region. It's a long story, and you guys can talk to them about it. It actually is going to be really good for us because I think we're going to get to keep staff a little bit longer. That happened on the 18th of November. Also, I'm sad but very happy for her. Emily Parsons has been stolen by Family and Community Health. She's getting a promotion to be a branch manager, and we congratulate her. She's been with the EMS Trauma Systems Coordination Office for about 6 years, and this is a really good move for her. But I will be speaking to my colleague about that. And then finally, I wanted to introduce to you, on my left here is Joe Schmieder. Joe is the State EMS Director, replaced Maxie Bishop. And Joe is from Pennsylvania. We stole him from Pennsylvania, which is fair game. He was the State EMS Director there. He's been out and about a lot, so many of you probably have met him or chatted with him. And he's already having an impact in Texas in the short time he's been here, and we are delighted to have him as part of our team. So, any questions for me?
This report under the trauma facilities, IAP, is that
In active pursuit.
in active pursuit? Would these be additional facilities, or could these be change in designations?
They could be both.
Okay.
If a hospital wants to upgrade, or if there has been a change of ownership, or new ones in the system, and I will tell you, we are getting a number of new ones in the system. I believe the trauma add-on is enticing hospitals to seek designation.
Any questions for Commissioner Perkins?
I would like to make just one comment, and that is this written report. I appreciate this. This is the first time that I remember seeing this since I've been coming to these meetings, and so thank you, and please tell them to keep doing that.
I will let Jay know. Thank you.
Okay, next we have, if there's no other questions for Commissioner Perkins, next we have the Division of Disease Control and Prevention, and I don't see Jana Zumbrun here. Go ahead.
Hello, I'm Tammy Sajak, and I'm here for Jana today to give you the update on what we've been doing with the trauma registry. So I'm very happy to tell you that we are finally getting ready to implement one of the things that was a recommendation from ACS, and that is that we collect national standard data. So starting on January 1st, 2014, anybody who is doing web data entry into our system, which is about 150 hospitals, will be doing that for the 2014 NTDB questions for any patients admitted on January 1st, 2014 and after. And hospitals that are uploading a file to us, we have released the file specifications to the vendors. We have scheduled a vendor meeting to talk about those specifications so that they can start creating the updates for their customers. And then they will distribute those updates to their customers, and then their customers will be able to upload the new data set to us. So we won't have, that means that because it takes several months for some of those vendors to update their software, that if they don't already have all of the 2014 NTDB questions in their package, that we will have the potential of ending up with not a full year of data for 2014 for NTDB elements that meet that data dictionary's year. We also are going to be moving into collecting the NEMSIS national elements this year, and that is slated for June. So we're moving pretty fast now with a lot of work that we've spent at least the last 2 years doing to get to this point. So it's pretty exciting times. We do have training webinars set up for December, for the people who are doing web data entry to identify the questions that they have not answered in the past that are the NTDB required data elements for 2014. So we will be giving assistance to all of our customers on what those data elements mean and what's the appropriate way to answer those questions. We also have been, as you know, because there's been many updates at the committees on what the Trauma Registry Work Group is doing. We've been working very closely with them. They have a very exciting recommendation that we allow data sharing on patients that EMS and the hospital both have treated. And so we're working on what that's going to look like, so you'll be hearing a lot more details about that as we move forward. We will be creating a communication plan so that we can make sure that all of the stakeholders in Texas are aware of this development. We feel like that this is outstanding progress and is something that we should be doing as a state. This will allow the EMS providers to know the outcomes of the patients, and it will also allow the hospitals to get access to EMS data besides getting it through a fax sent to them or a hard copy run sheet left at their place of business. So you will be being notified of when we're having webinars and other opportunities for people around the state to give us feedback on this recommendation so we can move forward with it. One of the things that the stakeholders have asked us for a while, we'll be moving forward on that probably within the next 5 to 6 months. We're going to purchase the AIS codes and put that into our system, and then we are also going to pay our vendor to calculate the ISS. And we have some opportunities. This is the time of year when we write our proposal to TxDOT for our annual funding, which would not go into effect until October 1st of 2014 because they're on that schedule. But one of the things that we are going to ask for in our proposal is for some funds to train, have a massive training in Texas for people on how to use the AIS. Any questions or comments?
Okay.
All right.
Thank you, Tammy.
Mm-hmm.
The Division for Regional Local Health Services, Assistant Commissioner Dave Gruber.
Good evening. I'd like to divide what I'm going to speak with you about into two parts. The first is those activities occurring in our health service regions, our field activities, and those associated particularly with preparedness in general. Regarding those associated in our field region, specifically associated with trauma, ours is more of a preventative role. So we have some programs there that are really very successful and continue to be successful. Specifically, our car seat program is always under extreme demand from the big community-based activities to, for example, I attended a migrant farm worker meeting in Muleshoe in which it was just as desirable in that small meeting as it was in the large one. So a very successful program and, again, significant to keeping kids safe. Additionally, texting and driving has now become one of the major efforts associated with our activities in the regions. There is a specific program in which the proctors put visors on kids and tell them to do certain things, and very effective in showing how texting can affect your activities. Another strong program out there is our bicycle safety program. Helmets are frequently given out at meetings, and again, all these contribute to safer and less trauma, which is a good thing. Most of these fall under our Title V Maternal and Child Health Charter for the health service regions. And one other thing that we're adding in our Lubbock region, our HSR1, is a infant mortality board. This is one of the first times it's occurring in the region. We're modeling it after an Arlington-based effort using the procedure that was handled here. We do child mortality boards, but this is the first infant mortality board that one of our health service regions will look into. There are some negative things going on that we've seen. Pretty much an increase in trauma activity based on fracking and the associated high volume of trucking with inexperienced truckers on roads, particularly around I-20 and the feeder roads going in there. Trauma is significantly up, car crashes and vehicle fatalities, and we don't expect that to decrease. In the future, and the future meaning now and beyond, our health service regions really are looking to increase their chronic disease prevention efforts. And again, when we talk about myocardial infarctions and associated diseases and trauma that can be prevented, this is a major effort. We are working with Jana Zumbrin's group to come up with coordinated programs to affect positive outcomes. Regarding preparedness, last time I was here, I spoke about a systems approach, and we continue to move forward with that. We've increased our community preparedness section contact with our internal staff in Austin, with our regional staff, and intend to expand out to partners. The translation of that is that instead of being a group that pretty much sits in Austin and gives out grants, we need them to be more active to ensure that they're out in the field, that they're coordinating field activities. This is not to say they're taking over field activities. However, the coordination that ensures cross-regional, cross-jurisdictional, and large-scale events needs to be increased on our end. We're also looking at cross-plan coordination, making sure that plans are plug and play with other plans so that we're not artificially separated by either RACs or HSR regions, and that those plans that each one has do match up with others and don't have mutual dependence on limited resources. We're looking in the future at cross-RAC exercises so that we have major exercises that, again, go beyond the dotted lines and looking at the realities of RACs supporting other RACs, trauma supporting other trauma, making sure that we don't have any glitches associated with that. Examples of standardization for cross-task operations include common communication plans and common operational concepts. Again, not to change the concepts that exist, but to make sure that they are integrated and that they match other operational concepts and plans. We'd also like to look at more examination of public health and healthcare delivery system interactions. And again, this is part of an expanding coordination systems approach effort. Finally, in that area, we want to look at the interaction of of the exchange of knowledge management and information brokerage, again, across regions, so that if an activity is occurring in one area, any other area, regardless of whether they're directly involved or may be involved in the future, has the same base knowledge as the event progresses, not having to play catch-up when they come in to help out. And then finally, I'd just like to add that we're adding someone to our group too. Her name is Beverly Pritchett, and the reason I bring her up here is that she has experience 21 years in the military as a Army colonel. She was a medical service corps running the field hospitals in Iraq and Afghanistan, and after retiring from the military, she was the preparedness director for Washington, D.C. for a long period of time. So we think this is a tremendous addition. Her focus will be on public health operations, and again, when I talk about this coordination across the board, building up the systems approach, that'll be one of her major focuses. So with that, that's the conclusion of my report. Any questions that you might all have, I'd be happy to answer. Yes, sir.
Can you elaborate a little bit more about the infant mortality committee as opposed to the child mortality?
Yeah, I think child mortality, and I'll admit this is not one of my strengths, so I think child mortality starts at a particular age. We're looking at birth to that particular age and looking at the same type of causes of death at that.
Any other questions? Thank you.
Thank you.
Next item on the agenda is the Preparedness Coordinating Council report from Eric Epley. Eric Epley. I know we saw him. We'll skip over that and move right along into the Air Medical Committee. Shirley.
Thank you. Try not to dump the water over here. The Air Medical Committee met yesterday afternoon and had several items that we went over. We are going to and are working with TAMES to investigate the possibility of forming an air medical work group to participate on the EMTF and the development of an air medical MOA. We've been working with this dishes for a while now, trying to get rates and all those kind of things settled on an MOA. This will take that chore away from them, and probably is where we should have done this to begin with. So hopefully we'll have some good news to report at the next meeting on that. And I guess I'm not sure what the process would be, but if that happens and we get all of that put together, do we need to withdraw the request for the MOA that we did before, or just leave it alone? Nothing? Okay. Alrighty. Also, we're going to continue to look at the future possibility of EMS students completing or doing some of their clinical rotations in the states bordering Texas.
That's been a problem for some for a good while. Joe has already done some groundwork on that, started some talks with some of the officials in the states surrounding ours. So want to continue to work on that and see if we can't come up with a solution for those students. The last thing I want to report on is we had a meeting in early October. When the model state guidelines came out, we took the model state guidelines and compared those to the draft rules that we had sent in a while back when that process was open. We found a few areas that we did not cover, or that we didn't feel like we covered well in our draft that were in the model state guidelines, so we wanted to add those to that draft. Early October we met, we drafted the language, and we've just about completed that process. We want to leave that, we're going to make that draft available to anybody that's interested and wants to look through it. If anybody has any comments on that, thinks we need to add something, subtract something, whatever, we would ask that we get those comments by January 7th. What we'd like to do is take those, get them all compiled, have them ready for our next meeting so that we can get those passed through Air Medical, bring them to the council for approval to send on to, I guess, Joe now. So that when they get ready to do those rules, we'll have those completed and ready to go. Okay. And I think that's it.
Okay. Any questions for Air Medical? Thank you. I think we saw Eric come in the back room, so we'll jump back up to the Preparedness Coordinating Council. And if you don't mind, go ahead and give your Disaster Emergency Preparedness Committee report as well.
So I apologize, I don't have the Preparedness Coordinating Council. I was out of town, so I didn't attend that meeting, so I can't brief that.
That's okay.
The GETAC Disaster Committee met Saturday morning at 9 o'clock. It was a short meeting, 90 minutes. We were done in about 75. We had a briefing from the Texas Department of Emergency Management for the STEER, the Texas State of Texas Emergency Assistance Registry, which is the replacement of that, the 211 registry where we would sign people up to get evacuated. Very good briefing from Dee Dee Powell from TDEM, and that system will be online shortly. They're going to be doing some beta tests in the early part of the late winter, early spring, so excited to bring that finally online. We had a briefing about the mass fatality efforts from the Texas Division of the TDMS, Texas Disaster Medical System, from Dr. Emily Kidd. Those efforts are ongoing, and the mass fatalities in each region will be going. There's some money from the state as well for mass fatality packages for employees and in some cases some equipment, so that process is ongoing as well. More to report on the mass fatality efforts in the next meeting. We talked a long time about it, EMTF, the Emergency Medical Task Force. And specifically, I'm happy to say that the bus 901, MPV 901, was doing calls all day yesterday and into the evening out on the interstate, and we saw the interaction with the Texas Division of Emergency Management. We actually had a TxDOT truck escorting the ambulance all the way to Alpine and back and forth. They ran about 16 hours and were transporting critical patients back and forth. I think they went to Alpine, to Big Bend, and somewhere else. Anybody remember where else? Where? Van Horn and Culberson. So big accidents happened out there, and luckily they were able to put and then some of those patients were critical, and were able to show up and get those patients back to El Paso. Talked about the Air Med Committee. I met with the TAMES members, and I also met with the Air Med Committee for GETAC, and we're moving forward with integrating air medical providers into the Emergency Medical Task Force program with an MOA. That will be done with the State Coordinating Office, and that's it. We're going to be doing a strategic plan in a meeting in January or February to work on our next steps, our next 3-year kind of what do we need to get accomplished. We've done a lot, so what's the next steps? Any questions?
Any questions? And I need to go back and ask Shirley this. Do you have any action items for council?
Not at this time.
Okay.
Except to apologize for being late.
That's okay. That's all right. Thank you, Eric. Shirley, you don't have anything from Air Medical? Okay. We'll go to Cardiac Care, Dr. Smalling.
He couldn't be here, Mr. Chair, so I'm going to do it for him. He said he'd submit a final report and that I could say whatever I wanted to, so I'm not sure where that completely. So if you really want to know, no. the main focus of our meeting was talking about a statewide STEMI registry and how we could go about getting that. Naturally, we're interested in funding. Everybody is, but rather than just arbitrarily have funding, we need to have an idea of what we need and what we want. There was input from the audience related to not only having data available back at the regions, but also that individual agencies could receive the data on their patients. And so there weren't any action items. There was primarily just a discussion about that.
Any questions for the Cardiac Care Committee report? Education, Jody.
Thank you very much. Education Committee met Saturday. We thanked all of our committee members. We had a lot of good applicants, about 19. Mr. Gonzalez, Ms. Lefevers, Mr. Salazar were reappointed. However, I think Jay Cloud is here. Jay was appointed. Jay, are you here? Stand up so everybody knows who you are. Thank you very much, Jay. We look forward to working with you. And also Mr. Ratliff from, Dr. Ratliff rather, from Temple. Dr. Ratliff, you here? No? Okay. We will see, hopefully, both of them at the January workshop. Gary Bonewall and Robert Nappage will be leaving us. They were received an ovation as well as certificates from DISHES and the committee, and thanking them for their service. We really only had one item, but it was an item that took up most of our time. And I need to give everybody just a little background so we're all on the same page. There was a proposed rule that incorporated legislation which passed in Senate Bill 215, and it related to the Texas Higher Education Coordinating Board proposing reducing associate degrees from 70 hours to 60 hours. Now, this proposed rule affects everyone. It's not just EMS, it's every associate degree going from a max of 72 hours to a max of 60 hours. We also looked, and it has the same effect on four-year degrees, moving those to no more than 120 hours. Referencing Chapter 9 of Education Code 19 of what's called SAC, Southern Association of Colleges, which is the accrediting body that every college and university loves to hear is coming, now requires a compelling reason to have more than 60 hours. If this amended rule goes through as is, it will basically go into effect the fall of 2015. And that it's not a unique situation to Texas because, again, this affects everyone. We had a lot of discussion, and there are a lot of terms in education for colleges, whether it's WECM or GIPWE, and we throw all these terms around, but basically WECM, Workforce Education Committee, and GIPWE, Guidelines for Instructional Programs for Workforce Education, basically help us write transfer credit curriculum so that when you go from one school to the other, if it's transfer, there's some basic content that has to be the same. If you typically look at trying to equate how many hours are in a degree, you can typically look at 16 contact hours for one credit hour. In doing so, that if you have 1,000 hours, and if you take that formula, it's going to take you about 62.5 hours to graduate with your associate. Well, what was the catalyst for this? The catalyst for this is that people have been receiving grant money and scholarship money, and much of this grant and scholarship money was not being used for degrees. Or it was being used for degrees with someone that now has 58 hours, never declared a major, and still getting money. So the thought was, if we can say, hi, we have a maximum of 60 for all associate and a minimum of 120 for all bachelors, that was supposed to work. I really wish Texas Higher Education Coordinating Board just asked a couple of us first, especially those of us in allied health, because when we started looking at this, the intent of the amendment was to incorporate all the existing rules for public education and to limit the number of semester hours. Well, in doing so, they thought that there would not be an economic impact, but I will tell you that every college and university is going to have to look at this because this will affect faculty load. This will affect contracts. This will affect calculation of salaries. So this is really a big, big deal. When we kind of sat down and really started looking at it as a group, we had several college programs. I can't list them all, but Grayson, Tarrant, Temple, Hill, Collin, Lone Star, several. I also received several letters from other schools, Austin Community College, looking at this and saying, what is going to be the best thing for us? How do we adjust this? Do we make EMT a co-rec? Do we make EMT a pre-rec? Do we take it out? Do we make it CE? Do you have to get credit for it afterwards? The thought was that if that associate degree requires a license or certification, we probably need to ask for a variance or a waiver to allow those programs to stay at the current 72 hours if that's what they needed, and to let each program decide if they needed 60 hours, 65, 68, 70, or 72 hours. Dr. Greenberg, my esteemed colleague to my right, even said that in part every physician feels like most of us need more, regardless of whether it was nursing, whether it was medical, or whether it was paramedicine. We certainly did not want to short them. The other issue that probably a lot of people going for their associate may not realize is that if the core content is not there, you can go to take that associate degree, transfer to a four-year university, and you still might be short core courses. We're finding some people are short 17 to 25 hours. So instead of being able to graduate with your associate and go right into your bachelor's, you may have to take 17 to 24 hours of additional credit to get you ready to even get into that four-year school. So dropping this to 60, certainly understand trying to manage the financial impact, because I think that was the original intent. However, as the committee began to look, we just didn't feel that that was the right thing to do. So, Mr. Chair, we have a motion, and that is that the committee would ask GETAC to move the recommendation to the Texas Education Higher Coordinating Board and have DISHES negotiate with them to consider an Associate of Applied Science in EMS as an exemption. That exemption is there. We're just asking for it in all EMS programs to let the program decide how many hours they need. If they can do it in 60, fine. It's very much, if you look at accreditation doesn't tell us how many hours you have to be accredited. It's can you do it with what you're actually doing. We think that concept would work extremely well, and we're just looking for support from GETAC for us to work with the exemption. If you look right now in Texas, we have currently 35 accredited paramedic programs, 28 of which offer associate degrees. So this has a big impact on most of the two-year institutions that we have. In most cases in Texas, providers are delegated authority working under the licensed physician. These physicians count on paramedic personnel to be competent in critical thinking, decision-making regarding patient care and based upon prescribed standards of care. I think everyone agrees that education is a key factor. So we're going to meet in January at a workshop at a location. We'll make it TBA. We're trying to figure out exactly where we're going to go to write a letter to Texas Higher Education Coordinating Board asking for that exemption for EMS in the state of Texas.
Second his motion.
Okay, I'm not sure what the motion was. I'm sorry.
Okay. Basically, the Education Committee is asking Texas Department of Health and negotiate with Texas Higher Education Coordinating Board to consider an Associate of Applied Science in EMS under the exemption to the 60-hour rule based upon the concept of EMS accreditation and better education. So
Okay.
that would be an action item for later.
Oh, so
Yeah.
it's for our next council meeting.
I think in our packet, if I'm not mistaken, we had a supplemental item. We do. And it was supplemental item, agenda item 5.I.4. So I didn't know if we could make this part of an action item at the end.
Okay, this says item 5.1 and then 4 in parentheses, but what is that an agenda item to? I guess is it referring to the GETAC agenda, or is this a different?
I think this is referring to the GETAC agenda because I did not see it in here under an action item, but we wanted to make sure that you guys knew that the Education Committee would be working on this and basically just looking at your blessings from the committee to allow us to continue to work on this, because this will be an agenda item in our January meeting and our February meeting.
Go ahead. You have to grab a mic.
Actually, I think what we need is to have this as an agenda item on the next GETAC agenda.
Correct.
So we can take action as a council.
Correct.
That's what he meant to say.
Okay.
Yeah.
Okay, right.
Okay. But we don't, there's no
We don't have
action.
to, no, we don't
action
have to take it,
tonight.
no.
Okay.
No.
All right.
No.
And so just so I'm clear, we're tasked to advise the Department of State Health Services. So what are we advising them to do exactly?
The proposed rule looks at the acceptable justifications for programs not to have to go to 60 hours. One of the programs we don't want to be forced to go to 60 hours is EMS.
Can the state do that? Can DSHS do that? Are we crossing lines?
You've caught me totally off guard. I'm sorry, I don't know anything about this law. I'm going to have to do some research into the law, what the Higher Education Coordinating Board was directed to do by the legislature, et cetera. There's a lot of questions in my mind about, but generally, we certainly can provide information to another state agency. We can answer questions. We can share information from this council. But the word negotiate does worry me just a little bit. I'm not sure that I can negotiate with another state agency, but I certainly can share whatever you guys want me to share and answer questions and have meetings with them, et cetera. But I'm not sure I can negotiate with another state agency.
I
If
think-
we need to change the word from negotiate, that's fine. Basically, it is the thought of the Education Committee that to say we have to go to 60 hours. When we're looking at 72 now, that's dropping 1/5 of the semester hours for someone to graduate from an accredited paramedic program is wrong. And we'd like the opportunity to look at that compelling, it's called an acceptable justification for us to stay at 72 hours or to allow a college or university to say, we're staying at 72, it might be 68 over here, it might be 65, but to take 1/5 of the curriculum out is just not the right thing to do.
Okay. And so y'all are going to be meeting about this in January,
Correct.
did you say? Okay.
Correct.
Well, I'll get my staff to do some research so
Okay.
we understand the whole situation a little bit better, and we'll come better prepared to that meeting.
Okay?
Thank you. I'm so sorry. I just was not aware of this.
Jody, isn't
Yes.
there a problem also with the 60 hours with National Registry?
I'm not aware of a problem with
Okay.
National Registry.
Okay,
No, we-
60 hours is fine with them?
We discussed this at the Medical Directors Committee as well. It was an agenda item for us.
Okay.
And obviously, the medical directors are in favor of more education and not less.
Right.
Jeff Beeson sits with the National Registry. He's on one of their committees, and he said that the National Registry doesn't have a set number of hours.
It doesn't? Okay.
Because that's a degree program versus what the registry does, which is to certify. So I don't think National Registry has anything, and I saw Joe shaking his head too. So if I can jump in with that part of our report from medical directors, we completely support the Education Committee in doing this. I think it should be an agenda item for GTAC next time, so we can take action.
Okay, so we have a motion and a second to put it on the agenda for the next council meeting, which would be in February. Is that
Correct.
okay?
And I think this is more than anything, I think this is a local issue for the colleges. I think each college is going to have to seek an exemption independently. But certainly it'll help them when they seek that exemption if GTAC takes a stand.
Okay, so we have a motion and a second. Is there any other discussion? All those in favor of placing this on the council agenda in February say aye.
Aye. Aye.
Any opposed? Motion passes. Anything else from education?
One more. I'm going to let Dudley handle that. We looked at House Bill 3556 and Senate Bill 8, looking at fraud and enforcement in EMS. Dudley made a great presentation to us, and I'm going to assume Dudley's going to make a similar one to us today. We also got an email from him. We will be looking at the 60-hour component. We'll also be looking at ethics and integrity in CE, and also looking at community college programs with EMS certificates in relation to reading, writing, and math placement. Some of the programs are looking, it's called TSI, Texas Success Initiative, whether that needs to be a requirement to get in. So we're just going to take a look at those items. Our next meeting will be January 9th from 9 to 3 at a location yet to be determined.
Any questions for Education Committee? EMS Committee, Dudley, wait. I've asked Dudley to give just the EMS Committee report, and then he'll come back and make a presentation on the work that that committee has done after we get through all the other committee reports.
Thank you all. We met yesterday at 1 o'clock. We got an update from EMSC for Children. We reviewed pretty much in depth the changes to 15711 that were delivered to the DSHS Council this week, with the changes in there from House Bill 3556 and Senate Bill 8. And I'm sure there'll be a presentation of those later. We reviewed those pretty much in depth and took some public comment, but I think the work we did with the stakeholders probably muted that just a little bit, because I think the state EMS director has taken those comments as we've gone through them and kind of updated and changed that to make it clearer and more specific as the stakeholders desired before it actually landed with the DSHS Council. So you'll go over some of that. We then looked over the report that the EMS committee has put together after our stakeholder visits. We spent the time, since you charged us to do that in August, traveling across the state of Texas. We were joined by our state EMS director and a couple of staff from DSHS along with him at all of those meetings. And I'll come back and give that report. Needless to say, it was a very powerful time for all of us, and I think we learned a lot, and I think the report has some really unique and good ideas in it from the folks who are doing this every day to try to help clean up our industry. The EMS committee did approve those and approved that document as our final report to GETAC, and so that's why I sent you a second email today with the word draft off of it that we'll go over tonight. We did not make any changes to the document, so if you have the one that reads draft or I have the one that doesn't read draft, I'll hand out to you so we can kind of go over it. It's the same document. We got an update on where we are on the draft rules of all of Chapter 157, and expect to see some of that back in 2014. And then we didn't have a report. They got the information right at meeting time on the work group that we have between us and Air Medical about patient care decisions when Air Medical and ground providers are both on the scene. So we'll have that back in February, and had an update on EMTF, and talked a little bit about drug shortages, got an update from Dr. Moore about a law that Congress has just passed about patient safety in drugs, and it looks like it may, based upon the information we've been presented so far, may hamper those agencies who are using compounding pharmacies for drug shortages. And so we're going to have to find a new way to overcome that as we move forward, as new drugs become short. And we were also notified that EpiPens are also in fairly short supply, and the price is escalating on them. So that's another item that we discussed as well. Got a report back from the Trauma Systems Committee Registry Work Group, from the EMS Committee representative, and then we took some comment and congratulated and said farewell to Kevin DeRamus, who was the rep on the EMS Committee that did not get reappointed, and he served with us for a number of years from Washington County, and wished him well and asked him to reapply in the future, which I think he may do. And that was it for our meeting.
Okay. Any questions for EMS Committee report? Thank you. Injury prevention, Shelley Stevens-Stidham.
Good evening. The Injury Prevention Committee met yesterday morning, Sunday. Unfortunately, we did not have a quorum, so couldn't take any action on various items on our agenda. We did talk about, we had 2 members who were not reappointed or cycled off of our committee, and we had 2 members of our committee who were reappointed, and then we have 2 new members coming on board. One of the things that we did talk about, though, was There is a national organization, a National Injury and Violence Prevention Organization, that is starting to put together some recommendations for hospital-based injury prevention programs. And so we thought that we'd kind of get a jump on it in Texas and put together a work group of our own with representatives from our committee, from TTAF, from Texas Trauma Coordinators Foundation, from the RAC, as well as DISHES, and look at some recommendations, possibly developing some suggested recommendations for hospital-based injury programs. At some point, we think that it's probably going to take the entire year of 2014 to do this, but at some point when those recommendations are ready, we'd like for to present them to GETAC and have the councils review them and possibly approve them. We did set workday meetings for next year. January 17th at possibly Dallas, although we haven't finalized that yet, April the 18th, July the 18th, and October 17th. And that was pretty much it for our committee. We have no action items for the council at this time.
Any questions from the council? Thank you, Shelley. Medical Directors Committee, Dr. Greenberg.
Yes, sir. We met on Saturday. We had a quorum. We are saying goodbye to Dr. Phillips and to Dr. Serbaugh, replacing them with Dr. Remick and Dr. Troutman. So we miss Dr. Phillips because he's leaving us from here too. We followed our agenda. We had discussion on several of the items. As far as action items for GETAC today, they are two of the current GETAC agenda items, items number 4 and items number 3. So I don't know if you'd like to discuss them now or wait till later. It's up to you.
Council, and anyone have a preference?
Makes no difference to me.
I say while we're talking about it, let's go ahead and
All right.
jump down to item 3.
Okay, item 3, endorsement of the NAMSP American College of Surgeons position statement on EMS spinal precautions and the use of long backboards. You should have that in your packet. It says position statement at the top. There was discussion and complete agreement that this is a reasonable document that should be at least circulated to EMS medical directors and EMS services in the state. I think the term we wanted to use was endorsement. Because the members of the committee felt that, quite frankly, it doesn't go far enough to address what we consider to be overuse of backboards and spinal immobilization. So, in fact, on our next agenda, and possibly coming to GETAC for the next agenda, would be a position statement and sample protocol about spinal boards. But for today, the committee would ask the council to accept our endorsement of this position statement.
Second.
Okay, we have a motion and a second. Any discussion?
I think it's
I don't know if Dr. Stewart was included.
I think it's a really good idea and very supportive.
Any other discussion? So we have a motion and a second to endorse the NAEMSP ACS position statement on the use of long spine boards by EMS personnel. All in favor?
Aye.
Any opposed? Motion passes unanimously. And now we'll take up item number 4 on the agenda.
Yes. Agenda item number 4, we worked, basically a work session in committee on a position statement on mental health care that I'm bringing to the council for review. And hopefully there's an updated version. Is that the updated version? Okay. We did some wordsmithing. And actually, the only part we wordsmithed is the position itself. We thought the preamble and the current situation was unchanged. We did wordsmithing only under the position, and we ask the council to consider it at this time. It may actually need a little bit of work after I reviewed it after the committee, because as you read it, it says, it is the position of the Medical Directors Committee of GTAC that, and one says, work with local and regional mental health inpatient facilities to create a standard definition of medical stability. It doesn't say who would do that. So there needs to be a little bit of wordsmithing and acceptance, which I believe council can do, because the question is if this, again, we're kind of back to, can DSHS work with other organizations, or would it be a subcommittee of the council, or who would do it? Got to bring you problems, man.
There are no problems, only opportunities. So in reading this, is it the Medical Directors Committee asking DSHS to work with local and regional mental health, et cetera, and that would go in front of them?
That's actually a good question, because again, as I considered this after we approved it, it was hard because we had it projected. And the truth is, there are a lot of players in this. So I'm not sure the exact wording we need. It may be that we make it more generic and say that it's the position of GTAC that we have everyone work together. I would have to do some wordsmithing, so that's as I bring it forward, I ask for your indulgence as to whether or not we can approve it as is, or if you want me to bring it back.
Dr. Greenberg, are you basically asking us to look, what I'm hearing is the four things on page 2 under position, right?
Correct.
Okay.
Yes, that's it. That is it. The only part we really ask for approval of is the position itself. All the rest of the information is the preamble, the scope of the problem, but the position is what is important, and the position is the part that we ask to be approved by council. So we ask for input, and it may be that this is also one of those items that needs to be sent out to other committees.
My opinion is that probably this needs to be more on a local or regional basis, perhaps even at the RAC level.
Yep.
And it may be that we need to encourage the RACs to set up an ad hoc committee in each one of the RACs to address this particular issue. I'm not sure that we can do that.
We can advise them to. I think, other than, I was about to make a very similar comment, that it looks like to me that at the sort of the way we're organized, that a lot of this, except for the number 4, would really be at the Regional Advisory Council level. I don't think we have to be as prescriptive to say that they need to set up an ad hoc committee, because it probably would work well with, each RAC may have a committee that could work with this, but it looks like to me, if you were to basically say that the RACs would be the logical local implementer of this, because as we know, each of the different regions, may be really different from each other with respect to resources available.
They are, and I think that one concern that I've got about just kind of leaving it rather nebulous is that some of the RACs have more participation than others, and I'm not sure how much mental health interacts with each RAC. And so trying to do something on a more formal basis may encourage those players to come to the table.
How about if we were to amend by insertion on the first line, the insertion of the word stakeholders? So it would read, it is the position of the Medical Directors Committee of GTAC that stakeholders, and then you go through 1 through 4. Would that be a reasonable, I believe my committee would approve that. This was something that got past us as we wordsmithed during the committee.
I think that that's a reasonable amendment.
Yeah.
Okay, so we have a motion to amend and a second. Is there any discussion on the amendment?
Well, I hate to add one more amendment, but would the word local stakeholders not be applicable? Because I think when you're trying to, I don't know, And then my other question would be, this is the first time I've seen the document, so forgive me, but the Attorney General put out an opinion regarding the direct transport of patients to mental health facilities, notwithstanding a medical clearance exam. Was that factored into this, or is that not applicable here?
That was discussed, the issue, and if you read the position statement, what it doesn't clarify is exactly what that medical clearance examination is. So that then it just kind of shifted where the argument is about where the peace officers get stuck with the person and whether or not that medical clearance can be done in the field by EMS personnel, which most of us think with appropriate medical oversight in select patients it can be done.
I was under the impression that they took away the requirement for a medical screening exam for specific patients. Did they not take away the Attorney General's opinion didn't take that away?
We still have all of our screened. They have to be screened.
But the receiving facility couldn't require the medical screening exam unless they themselves detected an issue. Is that not correct?
That is correct.
Okay, okay.
But it's leaving the field personnel and the peace officers stuck in the middle. It doesn't go far enough to define it, and we're hoping to help define it some more. So to get agreement on what is a medical screening examination.
Would we also not ask those RACs that if that's what we decide to do, to have the RACs make an executive summary and present that to us for their findings? If we put in here, we're asking the RACs to help implement this and to help do this, I'd like to see the RACs tell us what they're doing if they decide to do this, how they're going to implement this, what are they doing, because there might be some sharing of information that would help one RAC that another RAC might not have.
So if I understand the current motion, it doesn't have the term RAC in it.
Correct. That's correct.
So we're taking the term RAC out of this one because
It's not in here.
because it says with local and regional, we're just going to let that suffice. Is that correct? Okay.
Okay, so right now we're discussing the amendment to add the word stakeholders to the end of the first line under the position statement.
Local stakeholders or stakeholders?
I'm sorry, stakeholders.
Stakeholders. Yeah, he says he's okay with taking.
Okay, is there any further discussion on the proposed amendment? All those in favor?
Aye.
Any opposed? Amendment passes. So now we're back to the original motion, which is to review and approve the medical director's position statement with the amended word of stakeholder put in the first line of the position statement. Is there any further discussion? Seeing none, all in favor?
Aye.
All opposed? All right, motion passes.
Thank you.
Thank you.
For future agenda items for the council from the Medical Directors Committee, we are going to try to bring forward a position statement and possible clinical guideline discussing alcohol blood draws by EMS impacted by recent legislation. And I can give you all the specifics on that. I'll forward that with our next agenda request. And one of the issues that came up, which we had limited discussion of because it was not on our agenda, but will be on our future agenda, and I bring forward as to whether or not the council would like to suggest it to other committees, is that we identify a number of or instances of requirements for EMS to include air medical transport be mandated or coerced in situations where it's probably not necessary. And we would like to, we're going to discuss that at the Medical Directors Committee, and I don't know if there are other committees that feel strongly about that or would like to discuss that. It is not on the agenda today, so I don't know how much we can discuss right now.
I would have to have a legal ruling on that. Was it on your agenda in the Medical Directors Committee to discuss?
No, sir.
Okay.
No, it came up as a future, as a future agenda item. We will discuss it next time, but I didn't know if it was something the council might want to suggest other committees discuss at the same meeting.
Yeah, I think council can determine that if there's any other committees that it needs to be assigned to for their next committee agenda. And we'll just put it on the council agenda for next time. So any other committees or their chairs feel that it needs to be on their agenda for discussion? Air medical, obviously.
Yeah, I believe EMS committee would be applicable.
Air medical, medical directors, and anybody else?
Education.
Okay. Education? Anybody else? Trauma systems?
Trauma systems wants it.
Everyone.
What's that?
I tell you what we'll do. We will put it on every committee agenda, and then the chair, if they do not want it on that agenda, they can remove it from that agenda before it's published. How does that sound? Because it sounds like everybody needs input, and I think that's great. That's an extensive stakeholder system there. Is that okay? All right.
That's my report, sir.
And then it will be, thank you, and then the topic will be on the council agenda for discussion next time. Right, Pediatric Committee, Dr. Macias.
Thank you. The Pediatric Committee met on Sunday, yesterday. Unfortunately, we had 6 members absent, and so we did not have a quorum. So many of our agenda items we could not move forward with. We also did not have our child fatality review team update, as Susan Rodriguez could not join us either. The agenda items that we did address were the translation of our position statement for minimizing radiation in pediatrics. We had a discussion with Jerry Cogburn from TDSHS Radiation. Was very enlightening for what the current rules are, which apparently are not very, shall we say, rigorous for templates for enforcing or requiring minimum standards, but do leave the option for institutions that provide fluoroscopic guided procedures or CT at their discretion to come up with their own protocols. So we will be creating a statement in our next meeting, hopefully where we will have a quorum, that will provide some direction for revision of the rules that are to go in 2017, focused specifically at minimizing radiation in children and looking at standard protocols for that. We had our EMS for Children State Partnership Update, which I believe is on your agenda item, a couple of items down, so I will not address that. We also discussed pediatric transfer guidelines. We reviewed the Washington State Pediatric Consultation, and we are creating a task force that will include medical directors, RAC representatives, Children's Hospital Association of Texas, CMS, any other committees that want to be a part of that, and we certainly will reach out looking specifically at some guidance for templates for transfer guidelines. And then finally, we discussed trauma registry. Upcoming agenda items will focus primarily on the pediatric transfer guidelines, our role with the National Readiness Project through EMSC, and our position and strategies for translating into quality improvement initiatives, minimization of radiation. Questions?
Okay. Any questions for the Pediatric Committee?
Thank you.
Okay, thank you, Dr. Macias. Stroke Committee, Dr. Rutledge.
Good evening. The Stroke Committee met Saturday morning, and the first discussion item that will be of most interest to you guys is that in the last legislative session, Rider 97, Bill 1, approved $5 million funding for stroke. $4.5 million of that is going to go to a research consortium. $500,000 is going to go for a stroke database, what you would call a registry, but not longitudinal. Out of that $500,000, $88,000 is going to go to the RACs. And so that's nice to have some money. The way that money will be distributed is equally among the RACs over the biennium. The purpose of this is for stroke system development. And the Texas Council of Cardiovascular Disease and Stroke and the GETAC Stroke Committee have been working on those requirements and getting input on what you would have to do for that money. The general consensus is that money should be flexible. That is, different RACs have different needs. But also, we need a gap analysis to then go back to ask for more money at the next legislative session. So the three areas that we've been looking at are, data collection. Let me find that. Data collection, education, and transport plan analysis. That will go forward to the Texas Council of Cardiovascular Disease and Stroke December 6th. And so we'll have that information back to you as soon as possible. The idea, though, is to make it non-onerous, to make it easy for the RACs to do this and to give flexibility for them. For example, education, that might be public education or education of EMS. So that's good news. Our education and stroke work group met, and they wanted to, and they gave us an update that in this state we have required stroke training, but that is not part of the national registry. In that regards, the core is open, and the requirement is 4 hours of CEs per 4 years. And they've been working to try to help the medical directors and RACs with that. Announcements were, American Heart Association Southwest Affiliate is offering stroke coordinator CEUs starting in April 2014. And the other announcement was that the International Stroke Conference is meeting February 12th through 14th, so that's a conflict and many of our members won't be able to come during that time. Future agenda items for us are discussions regarding the Texas Council of Cardiovascular Disease and Stroke. The other $450,000 worth of that money is going to go towards a database. It's more hospital-oriented rather than sort of EMS-oriented for stroke. And it is a requirement for state designation of stroke centers that they be a part of a database. And so the consideration is that a recommendation be made that hospitals use the Texas Council of Cardiovascular and Disease Stroke database to fulfill their designation. And what we hope to do is then come back with that recommendation to the GETAC Council next time to get that approved so that that would go forward. And by recommendation, 90% of the people, hospitals already use the American Heart Association's Get With The Guidelines, which is the core of the database that's being proposed. And the recommendation would be that they all use it, but not make it inviolate, that if someone wants to use other databases, that would be okay. We have many other work groups that didn't present this time. We have a data collection work group, an EMS education work group, a transport bypass work group, and a trauma systems registry work group that didn't meet, but we'll have reports from that next time. So that's my report. Do you have any questions? I know one question you might have. So if it's approved, so if we can get the requirements approved by December 6th, how quickly can we get money to people? We were hoping that we could get money out by the first of the year.
Okay. Dr. Rutledge, in the statement earlier, I heard you say 4 hours of CEO for a 4-year period. Was that related to EMS?
Yes.
Okay. Asking for that additional hours or
No,
the hours that are already there?
It's just a reminder, it was a reminder that that is a requirement that is not part of the National Registry.
Okay.
Which is, I think not everyone realizes that that's not part of the National Registry.
Any other questions for Dr. Rutledge? Thank you.
Great, thanks.
Trauma Systems Committee, Jory Klein.
Good evening, Mr. Chair, committee members. The committee did meet yesterday. Can you hear me now?
Yes, we can.
So we have two members that are rotating off our committee, Dr. Craig Ryan and Dr. David Smith, and so both of those have been instrumental in moving the committee forward. So we will celebrate their participation at a later time since neither of them were there. So the first thing we wanted to talk about are the rules. We're still moving forward with the rule update. The second issue is we did create a trauma system performance improvement plan that the Trauma Systems Committee approved, and it came through your committee back in August of 2011. The rollout date for that to start the implementation is January of 2014. So we did revisit that. We did agree that in February we would have an in-service so that everybody's on the same page of how to move forward with that. In addition to that, we had an update from our trauma system work group, the registry work group, and that group is continuing to move forward. This is for EMS as well as for the trauma registry. There was also discussion from the other components of the registry. Brian Pertilla has represented EMS, and so for those of you from the EMS world, you know, he's really done an instrumental job in making us aware of the great differences between the trauma registry, which is a medical record we extract information from and enter into a database, versus the electronic medical record for the patient care record for EMS is your database. And so we're trying to learn how to work better together because you guys have data instantly. We don't have data usually for 2 or 3 months. And so there's a lot of guidelines regarding that or discussion. One of the things that we did recommend was to have regional representatives that could be champions for EMS as well as hospitals. There's a lot of questions of how to make that work. In addition to, we looked at data. We would like to have a data-driven system. I think some people have heard me say more than once, I love my red Mustang, but not having data to help drive the system in trauma is like driving that Mustang without a transmission. So the next work group that we looked at was Dr. Brian Eastridge has a trauma medical directors work group. That committee is charged with looking at guidelines for the geriatric triage as well as best practice guidelines. In addition to that, that group is looking at several other resources that we've asked them specifically, and again, they're looking at best practice models to bring to the trauma medical directors. We also had a recommendation last two meetings ago from Wanda to create a RAC work group that was initiated, and Wanda's going to take the charge of that. And then Jane gave us an update on the ACS trauma system consultation that we'll be rolling out. And then we had a other work group that we created, and it was approved, and that is a TQIP work group. And so those of you who are familiar with that, that's the Trauma Quality Improvement Data, where we take data, we send it to the National Trauma Data Bank, and then it goes over to the TQIP data for another $10,000. And so we do have several Texas hospitals that are participating in that, and it allows us to have better benchmarking. And through that process, we would like to see or explore what it would take to create a Texas TQIP so that we can compare ourselves to the other states as well as internal comparison within the state. And then one of the things that we ended with, we also approved a work group for our advanced practice providers with the goal of that group. It's going to be chaired by Kelly Sowell from Scott & White. That group will make a list of recommendations for the advanced practice providers to be in the trauma center. In addition to that, resources as well as job description recommendations for that group. And we ended it with the Affordable Care Act and how it impacts trauma. And so There was a lot of discussions about the standard dollar amount. We were asking for some guidelines from the state where to look for resources. Jane did send some resources to me, and I'll share that with the other committee members. And then the other question we had is who's actually looking at the Affordable Care Act? And if you look at Section 3, 3505, it's specific to the trauma system. So the question is, how do we get engaged at the state level to look at that? Can I answer any questions for you?
Do you have any action items for the council?
No, sir, not at this time.
Okay. Any questions for Jory? Okay.
Thank you.
Thank you. GETAC liaison summary reports are next. TTAF, Dinah Welsh, and as she's coming forward, we never want to be remiss in saying thank you for broadcasting these meetings and the committee meetings and storing the archives. They're very helpful.
Well, thank you. Thank you for saying that. Thank you all very much for having us and including us on the agenda. We had our meeting Saturday evening, and we had held board elections. Dr. Eastridge is joining our board. He will be our new vice chair. And Shay Watson also is joining our board. She's going to be the new RAC division chair, so we're thrilled to have both of them join us. Kathy Rogers and Dudley Waite were also re-elected. But with that, David Reeves, who has served TTAF since the very, very beginning, he has rolled off as the vice chair, but we want to thank him for his years of service to TTAF. We have, TTAF, we have begun to implement a RAC strategic plan, and one of the big goals of that plan is that we better educate legislators, the public, what RACs do, how they operate, their functions, how important they are to the trauma system, and so we've started to implement that. In January, we will begin looking at a legislative agenda for TTAF, putting that together with the help of the RAC EDs as well as our board. And obviously, we'll share that with y'all as we begin to piece that together on any changes that we'll be looking at. We'll always be looking at funding, additional funding, but looking at other pieces that we might add. We have launched a Just Drive campaign. I know there's been some others that have discussed texting while driving campaigns. We're looking at Just Drive, which is texting, but it's everything else, and including me putting my mascara on at stoplights. I'm not allowed to do that anymore. I'm trying to be more cognizant of that, but we have launched that campaign in 6 communities with the help of Texas Tech. They have done some research that we will have to share with GETAC in February. We hope to it's not just a campaign, but we're trying to have some research to go along with it on how we do change driving behaviors and patterns, and so look forward to being able to share that with y'all. A couple things that we have coming up. We have a data management course that we're going to be offering in late January, and then our EMS webinars will start back up at the beginning of next year. We have a fundraiser May 14th. Would love for y'all to attend that. It's going to be at the Texas Disposal Systems Game Pavilion. For those of you that have not been there, it is complete with 2 giraffes, wildebeest, a black rhino. It is a game ranch, and a lot of those animals roam free. Some of them do not because they might eat each other, but it's really a fabulous place, and I think it'll be a really neat special event, so I hope y'all will think about joining us, and that is all I have. If y'all have any questions, I'm happy to answer.
Any questions for Dinah? All right, thank you.
Thank y'all. Happy Thanksgiving.
Same to you. EMS for Children State Partnership Update, Sam Vance.
Good evening. I just wanted to give you all an update on the EMSC National Reassessment that's taking place right now with our EMS agencies, fire-based EMS, and first responder organizations. As you may remember, we were allowed to do a random sampling of all of our departments. As of today, we're a little bit more than halfway through our cohort, and as you can see from the national map up here, as of today, we are right at 46%, which is pretty good. We'd like to achieve at least an 80% response rate, hopefully by the time our cohort is done, which is on January the 8th. We have sent out letters and emails to all the departments that were chosen by the computer to participate. We've had help from DSHS. Chief Riley helped send out an email for us, and we have gotten lots of support from the RAC chairs and RAC directors. We have sent them the list of those departments who have not responded just yet, and they're going to be helping contact them also. Departments that were not chosen by the computer, if they would like to participate, they still can by filling out a hard copy of the survey, and their data will be entered at the end of the cohort. Other than that, that is pretty much it. I'd like to thank everybody for helping out with that, and thank those departments who have already completed the assessment. I've seen several of the folks at our booth across the street this week, and have spoken with them about completing the assessment, and they're all on board with that. We are at booth 509, so stop by and see us tomorrow morning. So other than that, that's pretty much it. Y'all have any questions?
Any questions for Sam? Thank you.
All righty, thank you.
Right, at this time we'll move to item 1, which is discussion regarding the laws and policies related to the licensure of non-emergency transportation providers, and that's in relation to Senate Bill 8 of the 83rd Legislative Session 2013, and we eagerly await the report from Dudley on this. While he's doing that, on behalf of the council, I want to thank Dudley, the EMS committee, and anyone and everyone who helped get this stakeholder participation done. Those that attended the meetings, all of it's very appreciated because we had very, very short notice from the legislature to handle this. So thank you for all your hard work.
Same thing you sent electronically, right?
Yeah, I sent it electronically. I just wanted to print it out because we're going to put it up here, and I'm going to walk through it a little bit like I did in the EMS committee meeting yesterday. It'll take a few minutes, but I think it's important that we go through all the points and give you a little bit of clarification, give you an opportunity at the end to ask any questions about anything that may have elicited your questions. And Chief, I appreciate that. I would like to ask the members, I don't always do the rah-rah cheerleader stuff really well, but I would like the members of the EMS committee that are still here and haven't adjourned for the evening to stand up. I know there's at least 2 of them I can see right here. That's you, yeah, and there's Lucille. So this is 3 of our committee of 11, and those 3 made multiple of the meetings. As you can see on the first page of the report, we met, the EMS committee went to 7 or 6 different locations. Our new EMS director went to a 7th in El Paso, and he drove there. But anyway, he's learning that we don't do that in Texas. Anyway, and Mr. Schmieder did join with us at all of the meetings that we held as well. And we held meetings in Houston, Harlingen, Amarillo, Dallas, Austin, and San Angelo. And what we did is we started off going over the proposed changes that I believe are item agenda number 6 in your action items to 15711. And then after that, we basically opened the floor for the stakeholders to talk about other ways to answer this charge given in Senate Bill 8. And specifically, the charge was that DSHS, in cooperation with Health and Human Services and the Texas Medical Board, were to conduct a thorough review, including the solicitation of stakeholder input regarding the laws and policies related to the licensure of non-emergency transportation providers. And so what we did is we kind of opened up the floor and said, what do we need to do? How do we limit fraud further? What do we do? How do we make our industry better? How do we drive the bad players out and not hurt the good players? And we just saw what they had to say. The number of stakeholders that we got to meet with were pretty much hard to fathom, looking back on it in retrospect. We met with over 400 different EMS providers in these 6 stops that we made. And we believe roughly 1/3 of all licensed EMS providers in the state had a chance to weigh in with their stakeholder input on the different items that were here. We took notes at every meeting. We didn't do anything with them until we were done, and then we sat down and we put those notes together in and basically said, how can we gather these up? And they really fell into 5 broad categories. And so I'm going to cover those broad categories just as quickly as I can, and we'll go through them. Number 1, and these are ranked in the order of their I don't want to say their popularity, but the order of the number of or frequency in which we heard about these particular items. And so the first one that we heard about in every stop and heard about at length in many of our locations was increased education and accountability on EMS personnel, healthcare facility personnel, i.e. hospitals and nursing homes, Medicaid managed care personnel, and patients. And in every location, like it says here, that we met, this group of suggestions came up from everybody, and we got a lot of really good ideas. The first one on EMS personnel, and these are the certified people that work on the ambulance, is that across the state we got input that said that first of all, we need to educate these providers in the laws and regulations affecting ambulance billing. It needs to be a part of their initial certification class. And then bullet point number 2, when they graduate and when they get certified, they need to have a jurisprudence exam that shows they know those laws and rules. We can't hold them accountable for things in the billing world, and they don't have to be billers, but they need to know what's right and what's wrong and how that system works. And we can't hold them accountable for following that and if we don't test to make sure they know it. So that was the first 2 items. And then we felt that we needed regulations in place so that EMS personnel are held accountable when they violate DSHS rules, if their employing agency can prove that the violation rested upon the crew member, or if the employee knew that they were violating a rule and chose to do so anyway. It would include, the rule would include that there had to be policies in place that require the employee to abide by the rule, a system in place to inspect and ensure that employees are following the established policies. And this input was offered by many stakeholders that felt that when EMS certificates have no risk to themselves, they continue to go along with it because a lot of times they're in need of that income. And so there's no real risk to them. They won't necessarily blow the whistle because they know if they get caught, if the agency gets caught, it's not really going to rain down on them too much. And we want to change that to try to encourage them. If they're working on a truck that doesn't have an AED on it, they need to tell somebody. And if their agency won't fix it, they need to let the state know that. And then tied to that then are laws developed to provide increased whistleblower protection on EMS certified personnel and to provide protection on EMS providers from inappropriate whistleblower accusations. So that was the one on EMS personnel, is basically just make them more accountable for the job that they're doing every day. And then healthcare facilities, Medicaid managed care organizations and their personnel. This was actually probably the hottest topic of all. And we started off with a bullet point to make sure we're perfectly clear. EMS providers who commit fraud do so of their own accord. Nobody's tricking them into it. Nobody's forcing them at gunpoint to do it. However, there are things going on all across the state of Texas where providers are being offered choices. Come move this patient by ambulance, or we'll call somebody who will. And in counties, several counties where there is one provider, and it's the county provider, and they move everybody, they have seen in recent weeks and months providers out of other large metropolitan cities 2 to 3 hours away showing up at their local nursing home to move a patient. And the providers feel that if we're going to be held accountable for following the rules, when we follow the rules and a facility gets somebody else in there who is not following the rules to move that patient, that facility should be held accountable for doing that. That it shouldn't always fall down on us. If we agree to do it and we do it wrong and we bill for it inappropriately, then fine. We've screwed up and we need to be punished for that. But when facilities are enticing or trying to get crews to, or get agencies to do that, we felt, I say we, the stakeholders felt that it was important that there was accountability there. The other one was, and they're kind of sub-bulleted out underneath there, nursing home and hospital personnel whose job require them to arrange for non-emergency ambulance transportation should have to undergo training on what legitimately goes in an ambulance and what does not. When a healthcare facility requests an ambulance for a patient that does not meet medical necessity or requests a transport at a rate that is not legal and the agency denies their request, the facility, this talks about them calling around to other agencies until they find an ambulance to perform the transport fraudulently. We believe the healthcare facility that does that should be held accountable for this practice. In addition, a Medicaid managed care organization, if they reach out and try to get an ambulance to do a transport at horribly low rates, or to do something, move a patient that's not medically necessary, or they use a provider that is not qualified. And we've heard stories about them using providers who are licensed at the BLS level to move MICU patients and those type of things because of the cost they pay, that those managed care organizations should also be held accountable for that practice. And then regulations should be enacted by DSHS hospital licensing, DADS, or the Department of Aging and Disability Services and the Health and Human Service Commission that require healthcare facilities, managed care organizations be held accountable if they use an inappropriately licensed EMS provider, and that DSHS be regulated that they have to report those to their governing agencies if they come across it in their investigation, that they have to report that. Next, under that category was if an EMS provider refuses to transport a patient from a facility due to the lack of medical necessity, we are asking that HHSC develop a tool that can be used to track that. So a few years ago when the air medical industry was having a lot of accidents, one of the things that came out was that ambulance providers will call for a helicopter, and that helicopter agency will deny that flight because of, let's say, because of weather. And then that ambulance agency will turn around and call another provider, and they may or may not share with provider B that provider A refused to fly because of weather. And so they turned that helicopter shopping. And what a lot of RACs have done in Texas is reached out with their air medical providers and developed ways for the air medical providers to share that information. That if they deny a flight for weather, the other air medical providers hear of that and learn of that in time to not take that flight if they've not discovered where that weather is bad. And it was just to make it safer. We're asking for something very similar. If somebody calls agency A and says, we want you to take this patient, and we say they don't meet medical necessity, yeah, I know, but the doctor signed a paper, and so you just come get them because if you don't, we're going to call your competitor. That there should be a way either the facility or the agency has to enter that into some type of tracking mechanism so that the other providers can see that an agency has turned that down for not meeting medical necessity. And also to assist the investigatory agencies into looking into these. If you see that Dudley Waite was denied because he didn't meet medical necessity and 2 hours later was transported by another ambulance provider, somebody ought to go look at that and see why that was done. And so it's just another tracking mechanism to help keep folks honest and a way for agencies to report those instances when they happen to them. And then lastly, patients. We feel patients who a lot of times are pulled into these fraudulent schemes need to be better educated. And ambulance providers maybe should be a part of that, where we educate them in exactly what is the appropriate use of an ambulance so that they can't get themselves into those binds. Not really any more accountability on the patient because they are the patient, and a lot of times they're trying to get a task accomplished to get to the care they need, but to help them understand what is legitimate and what is not so that they can better watch out for it. So that was item number one. It was one of the largest and most, I would say, across the state universal topics that we heard about no matter where we went and no matter the provider type. So that came out number one. Number two was to increase the number, ability, and processes of DSHS EMS regulatory personnel. Basically, again, across the state, the EMS transport providers are asking for more police. We do not feel we are regulated well enough. And it came out time and time again, and it's in there in a couple of places. I'll probably stumble across it in a second. We feel we have a lot of really good rules on the books that are not being enforced. And they're not being enforced because somebody's turning a blind eye. They're not being enforced because we don't have enough people out there to enforce them. So instead of passing more rules and more laws to regulate us, maybe we should try to enforce the ones we have really well and see what that does for our industry first. So our first one was more regulatory personnel or more cops. All EMS regulatory personnel should be dedicated to enforcing EMS rules and regulations and not used in other strategies. EMS regulatory personnel should be used for investigations, inspections, licensing, regulating, and providing technical assistance to EMS providers, first responders, and education providers. DSHS should develop and publish a discipline manual so that EMS providers understand the process and what's going to be expected of them and the course that will take. DSHS should work with stakeholders to develop a process to utilize EMS stakeholders in the regulatory and enforcement process, much like a peer-driven discipline type process that a lot of us use in our own agencies. DSHS should task GETAC with developing a deadly sin list of EMS provider rule violations. You'll remember a few years back when we passed legislation about what you could or could not have in your criminal record to do EMS. There were a list of crimes out of the section, I think it's 7G, and they're horrible crimes: murder, aggravated assault, anything involving a child, all of those things like that, that if you have that in your record, you cannot be certified. We want the same thing for EMS provider licenses, where if it comes up and somebody's done something, and it's the most egregious things you can do as a transport provider, then if they get to keep their license, then when they keep their license and they relicense, they go back to step 1 of the new requirements of 3556 and Senate Bill 8. So they don't. So if they've gotten past the letter of credit and their administrator of record has more years than what is required to take the course, all those exemptions are gone. If they're a governmental agency, those governmental exemptions are gone. And because they've committed an egregious violation, they have to go back and start over at square one in the new requirements of those 2 laws that a lot of us are exempt from because we've been in the business so long. And then the other one was if you have multiple enforcement actions. And we just threw something in there, for example, 3 violations in 2 years. Then the provider license should also be revoked, or the provider should be required to revert back to all of the requirements placed on new applicants as a result of those 2 laws. Next, we said DSHS should work with GETACs, RACs, and EMS stakeholders to find appropriate ways to require higher levels of participation in the regional level, whether that be with RACs, emergency medical task forces, and other regional organizations. Stakeholders felt that the more involved agencies were in their region, the more likely they were to abide by peer pressure of their fellow providers not to step out of line. And so there was a lot of thought that, you know, we need more than just this group that we've got participating. If you're going to transport people by ambulance, you need to participate in the region. That helps in the care in the hospital, and that helps with the peer pressure and the enforcement of rules. The more that we spend time together, people may not accidentally step off into a rule violation. The other thing is with additional regulatory personnel that the stakeholders asked for, we think DSHS should implement mandatory unannounced visits to new providers within their first 6 months of operation. They get a visit, they go into business, and they may or may not see an EMS enforcement person for 2 years or longer unless they're out doing spot inspections. We think if you're going to get into business to start with, within your first 6 months, out of the blue, somebody should come knock on your door and say, let me see your stuff, let's talk to your medical director, what's going on. And as a way to keep them honest up front in their process. Additionally, we feel that DSHS should initiate routine blitz inspections, is the term that came out of some of our meetings because of some experiences that our new EMS director had in his former state. And a lot of the blitz inspections need to be fast, and they need to look at the most critical stuff: oxygen, cardiac monitors, suction, that kind of thing like that. Do you have the stuff you really got to have to take care of a sick patient? It could be done very quickly. It's not keeping an agency tied up at a hospital for 45 minutes or an hour. It's a very quick thing, and they hit as many providers as they can when they're out doing that. We also felt that with new applicants submitting their initial license packet, they should be giving 2 additional attempts to submit any missing or incorrect pieces of that license packet. The word that, as we've heard it, is that sometimes folks will say, I want to be an ambulance provider, and they turn in their packet. And they say, well, you're missing item C, D, and E. And so then they come back and go, well, here's item D. And they say, well, you're still missing C and E. And they say, well, here's C and D again, but this time D's wrong, so now you're missing D and E again. And this goes on and on and on. So the stakeholders felt they should get 2 additional attempts. You turn in your packet, you say, my packet's complete, here it is. You get 2 additional attempts. If you don't get it done in those 2 additional attempts, you forfeit that process, you forfeit those fees, and you have to start over from square one. We also felt that DSHS should put timelines on how that information has to come back. So if they send it back to me saying you need item D and E, that I shouldn't have 90, 120, 6 months, whatever it is, to get that information back. That needs to be put into rule. And again, if I don't meet those time deadlines, my fees and my application process are done, and I have to start afresh. Stakeholders across the state also agreed that intent cannot be regulated, and if people intend to violate the law, they will, regardless of the regulations. The key is to provide more regulators with the tools to effectively and efficiently enforce the rules and regulations that are currently in place. Again, 1 and 2 were probably heard loudest of all. 1 definitely loudest, and 2 was also very loud as well. And this was said with DSHS regulators in the room, because folks know that the regulators can't do the job that's being asked of them. Number 3, This came out of a lot of discussion, some of the rules, the document that Chief Riley advanced when this first came on the agenda for GETAC. And across the state, no matter where we went, we asked the question, should there be two different licensing levels, emergency and non-emergency? And I think it was almost unanimous among the stakeholders that Texas should have one type of license for all ambulance providers, regardless of their service type. And again, this came from the stakeholders. I did not get involved in that. Some people know my opinion about that. But even in some places, you wouldn't, San Angelo, I thought they were going to come at us with pitchforks when we suggested that. So the stakeholders believe that we shouldn't. And one of the issues is, how exactly would you divide it? I mean, how would you divide emergency and non-emergency? So some of the things they came up with about why not. First one was that the general public does not know one ambulance from another. I mean, they see an ambulance, it's an ambulance. They don't know. A different license, the stakeholders felt could impact the provider or the regulatory agency potentially, but it would not make any difference in how that agency performs and will only confuse the consumers. Next, if we were going to regulate emergency versus non-emergency types of licenses, is what delineation would we use on that? Is it responding lights and sirens to the call or not responding lights and sirens to the call? Is it the billing definition of emergency or non-emergency? Or is it some level of patient criticality that we would determine whether or not they would handle emergency or non-emergency? We throw those terms around all the time, but depending on what angle you're looking at an EMS operation, they have drastically different meanings. And so that was another confusion factor that stakeholders felt we didn't even need to go there. And then lastly, if item number 2 can't be fulfilled with more regulatory personnel, the fear of a lot of stakeholders is if you license people in emergency and non-emergency, the emergency is where all the media attention is. Not when they're talking about fraud, but every day, day in and day out, response times, things like that. Nobody's sitting there saying, hey, it took that ambulance 90 minutes to move this patient out of the ER back home. Nobody's talking about that, but they are talking about the 15 minutes it took to get to the kid in the pool. And so let me see, because of the perceived impact of public safety, the stakeholders felt that there would continue to be good, solid regulation as best we can with the staff we have on the public safety agencies, but when that license was split, there could be a tendency to not pay attention to that other side and allow them to meet different levels of regulation in that we wouldn't do to our public safety agencies. And that could further, again, back to the confusion by the consumer and the ability to use those resources for things other than their primary job that they're out there on the street to do. So the stakeholders felt pretty passionately that should be one provider license type. And then another thing that came out of that that we didn't really expect, a lot of this stuff we didn't really expect, but one of the things that came out of there was that it's amazing, the ideas that are out there. But one of the things that came up was not only do we need more police and not only should we have one license type for ambulance transport providers, but somebody needs to start regulating the other pieces of medical transportation. Texas, several years ago, outlawed what are called gurney cars. It's stretcher transport, non-medical stretcher transport. No attendant. The patient cannot sit in a wheelchair, but they don't qualify to go by ambulance because they don't need medical attention. We'd put them on a stretcher, we'd put them in the back. Because of the lower cost of doing that, that started getting abused, and we started taking patients that maybe did need medical attention. And then we started taking patients that definitely needed medical attention in those types of transports. So Texas outlawed them. But after the Affordable Care Act and the decreasing reimbursement by Medicare and Medicaid and people looking at every transport, there's some systems in Texas saying, we would like to implement that into our system as another tool that, if regulated appropriately, could be an adjunct to ambulance transport. And then it came up the same about wheelchair transport, because they're not really regulated anywhere except maybe on a local level, much like taxi cabs are. And so it was thought that maybe we could provide some regulation there so that when somebody meets the qualifications of patient and they need medical attention, they go in the device that can, or the mode that can provide them medical attention. But if they don't, they go in another mode, but we've got to regulate how those modes operate and where that delineation is and where those folks go. And so that kind of came out in a couple of our stops, and I thought that it was unique enough to share with everybody and to give to DSHS. Number 4 was updates and enhancements to the 2 bills, House Bill 3556 and Senate Bill 8. We ran into a lot of things out there that people had some concern about, and potentially were downsides that may not have been intended. The first one is there's exemptions throughout both laws that provide exemptions to certain pieces of it for providers that are directly operated by a governmental entity. And what this does not include as exempted that then gets lopped into the rest of the regulations are the 501c3 volunteer organizations in the rural parts of our state, who now have to meet increased requirements on the administrator of record, who now have to get a letter of credit and now have to have a surety bond to DSHS because they are not directly operated by the governmental provider. Their sole function may be to run ambulance calls for that county or that city. But they're a 501c3 that then contracts with that city or county or ESD or whatever it is. And so the stakeholders have asked either, can we exempt that piece, the ones who primarily do 911 in that role, or can maybe the law have some changes added to it where those exemptions are population-based? So if you have a county less than 50,000, that it doesn't apply. Or that type of thing. So they were very flexible. It's just that a lot of these agencies struggle every day for staffing and funds and resources, and now they have all these additional licensing requirements piled on top of them. And in a lot of the areas, the Amarillo meeting was probably one of the most eye-opening ones because almost everybody there was a 911 provider. And they said, we don't really have a fraud issue up here. What we have is like a people issue and the ability to actually respond to calls. And these things are going to hurt us. And they laid out some things for Joe and myself and the rest of the EMS committee as we did that. So we put that in there. The requirement for new providers to only operate in the jurisdiction where they have a letter of approval from the local governmental entity for their first 2 years. Stakeholders all over the state said that should be expanded and may be required for longer than 2 years or maybe forever. And then the new administrator of record requirements of an initial education course, continuing education hours, and the ability to serve as the administrator of record for one agency should apply to all EMS providers, including governmental entities, and should not have an exemption for tenure in the industry. We felt like that we need more sophistication in our leadership. This has been a topic the EMS committee has heard for a couple of years now. The stakeholders echoed that. They all wanted to know why the governmental entities were exempt from those pieces of the administrator of record. And they really felt strongly that should be included because they want to raise the bar for everybody. And then as laws and regulations continue to increase, there should be a tie between compliance with DSHS regulations to incentives in the state's Medicaid program. You got agencies that are doing it right, they either get a few more pennies in that Medicaid payment, or the agencies who violate rules have pennies or dollars taken away from that Medicaid payment. So provide some financial incentive to agencies that bust their rear ends to follow these rules every day and try hard to do it right. And if they don't, and if they go out there and they violate and they develop that record, start cutting that Medicaid funding. It's happening for hospitals. It might as well happen for us as well. And then provide an up-to-date listing of administrator of records for all agencies readily available on the website so that local governments who have ordinances can contact that when they see a new agency in their area to advise them of their local ordinances, and then also to make it easier for reporting to be done to DSHS if we see those folks operating out of their permitted areas of operation in their first 2 years. And then lastly, that we felt that DSHS should also approve all providers of administrator of record continuing education, just like they do the CEs for the medical personnel. And then number 5 was to increase the requirements on some legitimate business practices. And we went around and we said, what else can DSHS do that just makes sense that maybe is not in the rules? And so we came up with 4 items. The first one was to require all providers to supply proof of ownership or lease of a legitimate place of business in their licensing packet. So, and it needs to be their primary place of business. And this is to prevent issues, the stuff we've heard about through our travels about DSHS showing up to do an inspection and it's a vacant lot with a mobile mini storage unit in the middle of it. So to prevent that, you got to show you either own or lease a place where you're going to do business, and that has to be where you're primarily doing your business. And then the second bullet point, the rules need to be put in place where only one EMS provider can be at each address. The third bullet, require providers to show proof of ownership or lease of all capital and inventory items that they need to operate at their appropriate level of care. So stretchers, ambulances, AEDs or cardiac monitors, whatever it is that the protocols say they need, if it's a capital item that costs money and is not disposable, they need to show proof that they own it. so that I don't borrow Justin's AED back there to get my license done, and then I hand it back to him after DSHS leaves, and I never carry an AED on my truck. If you're going to require me to have it, you need to require me to show you that I own it, or at least lease it, one or the other. And then develop a 5-year plan to require, and the 5-year plan, by the way, is just a number we threw in there. We were going to say medium range, and we felt like we need to put a number on it from what the stakeholders had told us. So we put in here, develop a 5-year plan that will require all EMS providers to have electronic patient care reports that integrate into the state EMS data registry and the other things that we're required to report to. And the thought behind that was it's going to make it, the quicker we get everybody in electronic and off of paper, it'll be easier to track trends and easier to spot fraudulent behavior early on in its existence before it gets out of control. And so that is what we did. That is the news we heard. Like I said, we laid this out there before the stakeholders and said, tell us what needs to be done different. And we wrote it all down and we kind of compiled it into 5 categories. So I'd be happy to entertain any questions y'all might have about any of these bullet points.
Anyone?
Dudley, no question, but thank you very much. This was excellent. I read what you sent out, and this was a lot of hard work went into it. Thank your committee. This is wonderful work.
Yeah, it's very impressive report. Of course, the devil's always in the details, and there's always unintended consequences.
Absolutely.
What's the next step with this document?
So I believe the EMS committee was charged to take stakeholder input and deliver a report to you guys. I think it needs to be given to them because they have to give whatever report they're developing, and hopefully this will be a significant part of it, to the legislature by January 1st. So they got like 5 weeks to get their work done. Sorry, Joe. I'll call you on Christmas, see if you're working.
Items 1 and 6 are tied together. Item 1 was to hear the report, and then item 6, if we choose to, we can vote to send that report to dishes.
Go ahead.
I just wanted to point out, I was able to actually make a few of the meetings myself, and kudos to the EMS committee and Dudley, but also all the people that facilitated the meetings. Mm-hmm. We had, the ones I went to were in great locations. They had rooms for us. And I want to personally appreciate everybody who's either watching over the internet or recording or in the room for actually showing up. I know that I've been in the industry right at 20 years, and I don't ever remember a time that we had 400 licensed providers actually have meaningful input on something that could actually affect them on a daily basis. So I think that it does show a trend that we want to clean up our industry. I was very heartened by the fact that we had at least 1/3 of the providers out there. And I know that it's very frustrating for those that try to do it right every day to feel like that we continue to suffer punitive damage because it's more rules for the people who aren't going to follow them in the first place. So I want to appreciate everybody taking part in that. And let me just tell the council that I feel like I'm kind of a lone wolf on the EMS part of this. That is my entire day job. And I would like to say that I wholeheartedly support this because it's a consensus document. And it gives you an idea, if you didn't already have one, that there are reputable providers out there that do want to clean up our industry. So I wanted to say thank you.
I guess just echoing Dudley, it's a tour de force. I mean, it's impressive. So thanks to you and the whole committee and all the EMS providers in the entire state. It's very impressive.
Anyone else? You know, in a state that, and I'm speaking just in my general perception, is generally conservative in nature, to have an industry come forward and say we need more regulations and we need more people to help regulate it, just to me, that speaks volumes about the professionalism in the industry and where we want to go. And so I think this document is just amazingly wonderful, having many years ago worked briefly for an ambulance company that, well, we just won't go there, that, let's just say, equipment moved from vehicle to vehicle, and I didn't work there long by my own choice. So if nobody has any other comments or questions for Dudley, we'll move on. Thank you.
And also, I would like to thank Joe and Phil, and I think Colin came on one trip. it spoke volumes having the state EMS director there, and he just sat there and listened, and helped us keep it on track, but just listened to what people had to say, and didn't try to promulgate his own solutions or anything else. He just listened to what they had to say, and he got to meet a lot of folks. After his first couple of trips, he learned where to fly to instead of where to drive to. So
I knew clear where I was.
And where not to drive to, right?
So anyway, thank you all for this opportunity, and I look forward to y'all passing this on to DSHS. Thank you.
Is it appropriate? Is it appropriate to make a motion at this point to accept this report and send it on to DSHS? And if so, I'll make that motion.
Second. Okay, so we're moving to item 6, and a motion's been made to accept this report and send it on to the Department of State Health Services. There's been a motion and a second. Is there any discussion? Is there anyone from the audience? I'll open it up to any comments from the audience at this time, since this affects so many stakeholders.
Mr. Chairman?
Yes.
I will say that the report does reflect pretty accurately of what was said at all the meetings. I mean, it was a very good report done by the committee.
Thank you.
And was it attended by hospital personnel as well?
Yeah, there was a nice cross-match across the whole state of all parts of the industry.
Thank you. I'll call for public comment one more time. Seeing none, I'll close public comment. We're back into discussion. Is there any more discussion on the motion to approve the report? Seeing none, all in favor, signify by saying aye.
Aye.
All opposed? Motion passes unanimously. Now we'll jump back up to item number 2, discussion of request to the council from the EMS committee to evaluate the availability of paramedics in certain areas of Texas.
We asked in August for your permission to be able to form a working group of maybe representatives from medical directors as well as education. RAC A did a survey of their providers and the number of paramedics they have, the number of paramedics they need, and where they're coming from. And they've developed a trend, a rather alarming trend, that they're not training as many paramedics annually in that part of the state as what they need. And so they've started sharing that with other RACs that are in the rural and frontier areas of our state. And so they asked if we could do that, and I thought it would be better to have medical directors and education involved up front on this. There's going to be a lot of people that question why we're doing it, but we've always had shortage of paramedics in different areas of the state. But we have some real numbers, and we have some real surveys now that are showing some trends that I think we need to get together and discuss. So Justin Boyd is the chair in RAC A who did the survey up there. He's on the EMS committee. He's willing to step up and lead this charge. We just need your permission to do so and request help from medical directors and education.
Okay, so you're asking for a inter-committee work group to talk about the availability of paramedics in certain areas of Texas, and you want someone from the EMS committee, some people from the medical directors, and education committee. Anyone else think there any other committees should be involved in that?
You want to do it before the end of the year, and Dr. Phillips will volunteer?
All right.
I tried.
I didn't share that with y'all either, but the EMS committee has decided we're not going to meet between now and our February meetings. We've kind of met enough. So we're not meeting again until February.
Darn.
That was my next question, Dudley. What's the time frame?
Justin, you want to speak? I was thinking maybe if we could have something back to y'all by August. I mean,
perfect. Yeah, perfect.
Give us a little bit of time and to get it started in February, give them a little time to do some work, evaluate the numbers that have already been collected, and then come back with something.
And let me suggest that the committee chairs then select 2 members from each of those committee to would that work? Is that okay with council?
So that needs to go on.
Okay.
So I'll make that motion, if that needs to be a motion.
Second.
Okay, we have a motion and we have a second. Any further discussion? And the motion being that there be 2 members from each of those 3 committees to form the work group. Is that correct?
To form a work group to identify where the paramedics are trained and currently working and as defined.
Okay, any further discussion? Seeing none, all in favor signify by saying aye.
Aye.
All opposed? Motion passes. Thank you. Item number 5 is to determine possible GETAC strategic planning session dates in accordance with Health and Safety Code, Chapter 773. We need to get back on the council strategic plan. We're looking at dates the latter half of January. I believe Director Guerrero has sent out a request for your availability. We really need to get back into that strategic plan. There's some holes that need to be filled, and we need to refresh it. In fact, our strategic plan, council said, should be reviewed every 2 years, so we're up to 2 years and then some. So I don't know that there's any action we need to take tonight. Just please let Director Guerrero know your availability within a couple weeks, because we have to secure a facility and a facilitator and those kinds of things.
I don't remember getting an email about January.
You did?
I don't.
Oh, okay. Okay. I stand corrected. A specific date wasn't looked at, but we were looking at the latter part of January, but I think she's waiting on everybody's availability to come in to really nail that down. All right. At this time, we'll accept any general public comment from the audience. General public comment from the audience.
Chief Ryan?
Go ahead.
Okay. I'd like to, since I don't see any general public coming up, I want to make one little comment. My term ends in January 1. And as your public member 6 years ago, I didn't know my EMTF from my dishes, I'm telling you. And I thank you so much for teaching me a language and educating me about trauma and EMS issues. The sheet of acronyms that Jane and Fern gave me were absolutely priceless, and I still carry them with me. When Texas citizens need your help, all your committee work, your personal sacrifices pay off in a big way. I commend each and every one of you for all your hard work and for your diligent effort to continually make your committees better. And I just thank you so much for your outstanding service for this wonderful state and all the citizens in it. And just at a very personal note, I want to thank you for your kindness, your openness, your help, and your encouragement to me while I've been on this committee. And it's been my honor to serve you and to serve with you. Thank you very much.
Thank you, Linda. We certainly hope that the governor uses wise judgment and reappoints you, because you have certainly, hint, if you're listening, Governor Perry, because you've certainly set the bar for the citizen position on this council for as many years as I've been on here, and it is a pleasure to have you, and I know the stakeholders are fortunate to have you on this council.
It's been my honor to know each and every one of you.
Mr. Chair, I think
Yes,
out
sir.
of all the members on this council, including those of us who've been here a while, we have not had a more supportive, more gracious, more informed public member of this committee than we have in Linda Dickerson. Thank you.
Oh, thank you. Absolutely true. Thank you. I agree. Thank you.
Any other general public comment? I will close a public comment at this time. I was remiss in thanking Judge DeLoach and Dr. Greenberg for coming to Austin to help us select the committee members. It is extremely competitive to get on the committees. I think that shows that we have a good process. If you were taken off a committee, it wasn't because we didn't like you. It's just we have so many people we got to rotate on, and you can always reapply. Next September is when you can reapply, and we encourage you to do so. The other thing is, this is Dr. Phillips' last council meeting. We've been on here 6 years, correct? Maybe a little longer?
They've all blurred.
It's blurred. Dr. Phillips has chosen not to be reappointed, and we really appreciate your hard work. You've been an integral part of this council and provided valuable wisdom and advice to us, and you are definitely going to be missed, but we know you're not going away and are working in so many other areas of the state and profession, so thank you. All right, any other comments from council?
I
Go ahead.
have one, just kudo. In the North Texas area, the ice and snow kind of got a little bit bad, but out in El Paso, I want to say that I'm very, very impressed that over the duration of my tenure, the EMTF programs and all of the ambuses and everything came to fruition. And just being here when all that was going on out there and realizing that patients were being moved in mass, coming from an ambulance perspective where it's generally one or two and you got to muster a crew and the truck's not best suited for that. I just want to say that we're really headed in the right direction, and sometimes we're so used to hearing how well those guys are formulating and doing their job that I want to throw out a kudo, because it's very nice to actually see something with so much sweat equity, hard work, and money put towards it actually function, and I just wanted to say thank you to those guys.
Any other comments from council? Well, then thank you all again for loving and respecting each other on our journey together. And on behalf of the council, we wish everyone a safe and happy holiday season. And we will see you in February. Meeting adjourned.